Welcome to Season 3 of HealthStyle, the podcast from Kingsbridge Healthcare Group. Kingsbridge is Northern Ireland's largest private hospital group with hospitals and clinics north and south. Each episode of HealthStyle introduces you to one of the Kingsbridge clinical teams and asks real patient questions on your behalf. My name is Avril Keys and I'm here to host the podcast today. I don't have a medical background, but I have been a patient of the hospital myself back in 2021. I'm here to break down the medical terminology so that it's easy to understand the treatments and pathways available in each specialty. On today's podcast, I'm joined by Ciara McGoldrick, who is a consultant plastic surgeon specialising in treating women with breast cancer. Hello, Ciara, you're very welcome to the HealthStyle podcast today. Thanks for joining us. I wondered if you could start by telling me a little bit about your own background and how you've ended up working in this area.
So I went to Queen's University here. I'm from Belfast and finished medicine and was totally captivated by surgery. Knew that that's exactly where I was going to end up, and started off in surgery and then was really drawn towards the diversity of plastic surgery. So I started my training in plastic surgery, and then towards the end of my plastic surgery training I had developed an interest in everything to do with women's breast reconstruction, and at that stage realised that there was a bit of a knowledge gap in plastic surgeons doing the reconstruction, but not necessarily having anything to do with the breast oncology or the treatment of the breast cancer. So I applied for a national fellowship and was awarded a fellowship then, which brought me to London, based in Chelmsford and the Royal Marsden. So I'm now dual trained then in breast reconstruction, microsurgery and breast oncology. I then took up a post in the City Hospital in the NHS, and then soon after that started my private practice here in Belfast. So it's been a reasonably long process, but I'm very happy with where I've ended up.
Yeah, lots of experience across lots of different scenarios, I'm sure. And is there a typical day? What does your day look like?
So I probably do more operating in a week than a standard surgeon, in that I would have sort of 2 to 3 clinics a week. Some of those are the sort of red flag, urgent, one-stop clinics where patients are assessed for breast cancer. I have a reconstruction clinic where I meet with patients considering reconstruction who've had reconstruction. Then I have a results clinic where I relay the results of biopsies and tests and things that obviously is quite a difficult clinic for me and the patients. And then I also do some of my private work, which is really both reconstruction and more aesthetic or cosmetic breast and abdominal surgery.
Okay, and we'll come to talk about some of that in a moment. And I suppose your combined training you've discussed there allows you to treat breast cancer right through from diagnosis through to surgery. So what does a pathway look like for someone who presents needing?
So quite often a patient will find something in the breast that they're concerned about, contact their GP, who will very quickly refer them on to us in the NHS in a red flag clinic, and they will attend for what we call a triple assessment. So that's a clinical examination, breast imaging, usually in the form of ultrasound and mammograms, of which there's a variety of types, and biopsies. And the aim is to give those women that information there and then on the day. So it's a lot of information. It's a long session for the patients going through all of that. But the aim is that for 90% of women attending that clinic, we'll be able to give them a diagnosis that everything is normal and they can go back to their lives and forget about the whole episode. Or for some women, they will need further tests, or we're waiting for biopsy results and we have a suspicion that there is a breast cancer there. And for those women at that very first appointment, then they've met me, and we have developed a relationship. And it means then that if we do find a lump or that we need to remove or we need to do a mastectomy, that we already have that relationship there. While in the past, if you had made that relationship with a surgeon and then it turns out that you decided to have reconstruction, then you're going off to meet a separate person, have develop a different relationship. There's obviously a delay in those appointments being allocated. And I very early on in my career realised that there's a very emotive, very close bond between a patient and their surgeon in that situation. And I felt that it was important that reconstruction was up there in terms of the options for a woman as part of her overall cancer care, and that's sort of where I inserted myself, and that's the role that I play in the City Hospital, and now I end up taking a lot of very more complex patients that maybe are opting for reconstruction, and so I find that patients maybe younger patients or maybe patients who we are anticipating may need a mastectomy are more likely to end up at my clinic than another patient.
And it's probably nice for you to see the beginning to the end as well.
Absolutely. And you know, it's such a very raw set of emotions whenever this is coming through. But to be able to reassure them that, you know, I will be there the whole way through is very satisfying for me as a surgeon on a very selfish level.
And so you were involved in, and you'll have to just explain this one to me, the first ever DIEP breast reconstruction in a private setting, and that was within Kingsbridge in January 2021.
Yeah.
So if you could explain to us what that involves and the impact it has on your patients.
Yeah, so that's probably what I spent the latter 3 or 4 years of my training learning how to do to a degree of proficiency. So it's really using the tissue from the lower part of your tummy, the sort of squashy bit between your belly button and the top of your pubic hair that most women have after a certain age, and taking it on its own blood supply from the groin, disconnecting it and reconnecting it into a blood vessel that runs behind your ribs, and using that tissue to mould a new breast. Now, it will never be exactly the same as the breast that was removed, but that's most commonly done in our practice on an immediate basis. So a lady who finds out she needs a mastectomy, we would plan to do that. So the day she has her mastectomy, she will also have this done at the same time. So when she wakes up, she will look like she still has a breast mound, albeit that the tissue on the inside of that skin had come from her abdomen, and she'll have a scar similar to a tummy tuck scar in the lower part of her abdomen. And psychologically, we have good evidence now that shows that those women do a lot better. They don't go through the psychological trauma of feeling that a part of their body has been removed. And it's wonderful that we are now able to offer that. That option was not available in the private sector, particularly in the north of Ireland. And so myself and my colleague Chris Hu felt that it was really an area of need, and that these women were being disadvantaged, that if they'd had a mastectomy, that they were waiting, and a lot of these women felt that their life was really on hold. And probably the impetus for us, while we'd started to do this in the City Hospital back in 2019, really COVID was the impetus for us to really look around and see what the options were, because while reconstruction was put on hold in the NHS, we knew that there was this demand that was building and building. And so Chris and I approached the team in Kingsbridge and asked if they would consider this as a priority, and they very kindly did. And there's a lot of background work that to develop any new procedure in a hospital, and that was put in place, and we did our first case in early 2021 and really haven't looked back since. And so it's nice for these women to feel that there is another option. A lot of time people particularly I find women with breast cancer have a lot of guilt that they have had their cancer treated, and that they should be grateful for where they are in their lives now, and that they don't want to put themselves as a burden on the NHS when they know that there are other women that are waiting as they were waiting back whenever they were diagnosed. But it doesn't get away from the day-to-day experience of every day when you get dressed being reminded that you had a cancer, and that you're forced to continue to be a patient when psychologically you're ready to move on. So being able to offer that for women has been really very satisfying, to the point where we mainly do immediate reconstructions in the NHS and mainly do delayed reconstructions in the private setting, either years after a mastectomy or sometimes months after a mastectomy, where the initial cancer has been removed, and then we're able to do it, say, after the patient's completed chemotherapy, for example.
Okay, it sounds amazing. And presumably then within your private work, you also carry out cosmetic-led procedures. And I suppose, what would be the differences between cosmetic work and plastics work?
Yeah. The Greek for plastos is to mould. So really plastic surgery is any moulding of a body. And I suppose in my mind, it breaks into sort of reconstruction, where you're trying to put a form and function back together for a patient where it has been lost either through cancer or trauma, or perhaps congenitally it never developed in the first place. And some women, for their breast, have never developed, and they're in that situation. Cosmetic or aesthetic surgery is really where you're trying to enhance what is normal, to make what is average better than average. And that again is very subjective, because some people are entirely psychologically traumatized by what is a normal variation on anatomy. And I spend a lot of time in clinic talking about what is a normal breast, what is a normal tummy, and either reassuring people that they are normal and that that the risks of surgery probably outweigh the benefits they will get from it, or acknowledging that yes, this part of your body is different from another person's, and that there may be something that I can do to change that. And whether I enhance it or improve it is very much in the eye of the beholder, and I'm probably always very conscious that I don't make bodies better, I do make them different, and that it's up to that patient themselves to feel whether that difference is something that they are willing to undergo, undoubtedly the discomfort of surgery, the scars associated with surgery along with that.
Well, better, I suppose, it means different things to different people.
Exactly.
And I suppose, I guess leading on from that, what do you do if someone presents with you really wanting something that you are not comfortable with them doing?
I think as a plastic surgeon, we're particularly tuned into body dysmorphia, and the sort of general rule of thumb is if someone presents to me with a problem where they're saying, I can't, this problem is interfering with my day-to-day life, it's interfering with relationships, I can't go out to work, I can't socialise, and I examine them and that body part to me is within a very normal range, that highlights to me that this person is not psychologically processing what is a very normal thing. And for those patients, sometimes the consultation itself can be very therapeutic. But for those particular patients, we always would be including the services of a clinical psychologist. And partly that is to help, if they do have body dysmorphia, to diagnose that and get them the help that they need with that. Sometimes the patient doesn't have body dysmorphia, but this thing has become a focus that is disproportionate to where they are in their life, but falls short of that diagnosis of body dysmorphia. And those patients quite often will need psychological support in terms of, what if this surgery doesn't go well? What if you don't get the result that you were really hoping for? What if you have discomfort from it? How are you going to manage that? How are you going to get on with your day-to-day life if you feel that things have not gone according to plan? And those tools that really a psychologist can give a patient are really vital and important. And Absolutely. So we have very low threshold to get a clinical psychologist involved, and thankfully there's a number in the team in Kingsbridge that we can call upon. I also have a very experienced specialist plastic surgery nurse called Pauline Williams, who sees all of my patients, myself and Chris Hugh's patients, in the preoperative setting for preoperative counselling. She's 20 years experience and has seen every bad, good and indifferent thing that has happened, and so she will quite often act as a second pair of eyes and ears for patients. So if she gets a sense that maybe there's something going on in this patient's life that maybe I haven't picked up in the first consultation, that acts as an extra layer of a safety net for the patients, for them, because if you're not psychologically in the right place to undergo this, it's important that we divert away from an operation that could have consequences for you further down the line.
Yeah, and presumably as well, I'm sure you have to be careful that what a patient thinks they're going to get from a surgery is what you can deliver, and maybe their vision of what it might look like. Yeah. I'm sure it's
absolutely
difficult.
And both Chris and I both have a little folder of on our computers of great results that no one else will see, because I don't ever want to show a patient my best results. I want to show them the very average results, the not so great results, because I can't guarantee that all the planets will align each and every time. And it's much better that people have an idea, well, even if the worst case scenario, even if this and this thing goes wrong, I still will be happy that I made this decision in the first place.
Excellent. Yeah, that's good to know. We've had some questions come in, and one of them was with regard to breast reduction surgery. So could you explain what this procedure involves and what kind of criteria I suppose you'd be looking for in a patient for this?
So breast reduction surgery is one of those win-win operations in that, we very rarely have a patient who regrets having a breast reduction, in that if a woman has got to a stage where she feels her breasts are so large that it's interfering with her ability to wear the clothing that she wants to wear, but more importantly, it's hurting her back and she's got a sore neck and she gets a rash under her breast every time it gets a little bit warm. It's difficult to find a bra that fits, and that they're very self-conscious in interactions with people as a result of them, those women normally know their own mind. They have come, it's very rarely that someone comes to me after thinking about having a breast reduction 2 months ago. It's normally 20 years they've been considering having it. And then as time goes on and bodies change and, you know, people have children or they become menopausal and their breasts don't change, and the sort of impetus for it increases over time. So it's one of the groups of patients that they rarely, I'm not going to change their mind. If this is what they have decided, this is what they've decided. There are some risk factors for it in that whenever we do a breast reduction, we need to maintain the blood supply to the nipple. And the blood supply to the nipple comes down through the upper inner part of your breast. So there is this limit to how small I can make a breast. So if someone comes to me and they have a double G cup and they want to be a B cup, I have to say, I can't make you a B cup and keep your nipple alive, because I need to maintain a certain amount of tissue in order to keep the nipple alive. But even that considered, there are very few patients that aren't suitable. If someone is a smoker, I will ask them to stop smoking for 6 to 8 weeks before surgery. There has always been a debate in sort of plastic surgery circles about whether this surgery should be offered for ladies that are heavier. Mm-hmm. So the recommendation is that you should hold off on doing any elective surgery if somebody has a BMI of over 35. And that's because the anaesthetic risk increases after that. So that's a very clear cut. I don't want to put someone at risk of having an event on the operating table if we can avoid it. And most people are very reasonably accept that is a limitation. On the NHS, however, the cutoff for having a breast reduction is a BMI of 25, which is a normal weight. And there's no clinical evidence that if you have a BMI of between 25 and 35 that you won't benefit from this procedure or that you're at increased risk of adverse events. It's very much used as a rationing tool. I think we want to make sure that we're not providing cosmetic procedures on the NHS. However, it means that there's an awful lot of women fill in between that gap, and a lot of women will have been told by, say, their GP or a doctor they've seen in the past that they're not suitable because their BMI is over 25. And I suppose I see a lot of women in that gap between a BMI of 25 and 35. What I would say is that if you don't have any other risk factors, if you're not a smoker, if you're not diabetic, if you're otherwise fit and active and getting on with your life, then actually the vast majority of patients do very well with a very low complication rate. So I would say that the vast majority of patients are suitable with some limitations. I think that we have to be realistic that by me reducing your breasts, all of your body may not be exactly to your liking. Mm-hmm. And I do have a number of women that whenever I reduce their breasts, they suddenly have seen their abdomen for the first time in 15 years and become very self-conscious about that. And I do draw their attention to that, and that they may be more likely to need small revisions, or that if they go on and lose a lot of weight or gain a lot of weight, that their breasts are going to change. But most women are very sensible and they understand that that's the way their bodies are going to change, and I'm not telling them anything that they don't already know. So
and what's the recovery like after breast reduction?
So I always, the sort of rule of thumb would be 2 weeks of being at home, feeling a little bit sorry for yourself and needing other people to do the grocery runs, but being able to care for yourself so you can wash your hair and get showered and care for yourself. But you wouldn't be in a great position for lifting small children in and out of a car, or, you know, lifting heavy things off a shelf. By 4 weeks, most patients are back to moving around as they normally would. And then by 6 weeks, I would expect you to be healed and be back to work and doing all your normal things, including normal physical activities. So if that's going to the gym or running, I'd expect by 6 weeks that you would be there.
Excellent.
There's always an exception to that. Not everyone goes along that pathway, but that would be a general rule of thumb.
Okay, that's great, Ciara. Thank you. I've also had a question from someone who's had breast implants a number of years ago and would like them removed. Is this something that you do in your course of work, and what's involved? Same kind of questions, the downtime, the impact on your life.
So that's becoming probably a more common request as we have a larger population who've had implants as the years have gone on. And the answer is generally implants can be removed if that's what someone wants. Undoubtedly, the breast will look very different when the implant is removed, and there's a variety of options, and that's probably the longest consultation that I have, in that we can go from just removing the implant and doing nothing more through to doing a breast uplift, putting fat into the breast, and doing some other modifications to try and optimize the appearance of the breast afterwards. And that really comes down to how that woman feels about her breast, where her priorities are at that point in her life, or time, or finances, and what tissues they have. So has their own natural breast drooped over time over their implant? And do they have fat elsewhere in their body that I can move and move into the space? Are they concerned about their health? Has there been any symptoms associated with that? Are they keen to have an implant again, or do they think that's them going to be implant free? And there are a lot of issues around that. Fortunately, as time has gone on, we've been able to build up a bank of women who have had this surgery and all the variations of it. So we spend quite a lot of time looking at photos to try and pick a woman that looks similar to them, and the options that they've gone for, so that they can have a realistic expectation of how things are going to look, because their breasts will look very different after they're removed. But while it was a woman's choice to have their implants put in the first place, it's also her choice to have them removed.
And you talked about symptoms of people actually maybe being unwell because of the breast implants. Can you say
there's
more?
There's sort of two categories of patients. There's the more serious one. There is a lymphoma associated with a certain type of textured implants that we've only really become aware of in the last 10 years, and it's extremely rare. Sort of 1 in 5,000 women with a textured implant will develop this. The symptoms of it are swelling and lumps in and around the implant, and the treatment for that is to remove the implant and the tissue that grows around it, or the capsule, which is where this lymphoma grows. And if it's treated promptly, it has an excellent prognosis, and people go on and can live their lives and put it behind them. And as the sort of publicity about that has become more to the fore, there are women who are very anxious that their implants are there, and are there symptoms associated with that. So we spend quite a lot of time trying to work out where they are with that. And then there's another category of women where they seem to be very sensitive to the inflammation associated with having a foreign body in your body. And they have a variety of symptoms where they have, joint pain, or hair loss, or dry eyes, or fatigue, or brain fog, and this has been dubbed a condition called breast implant illness, and it's not an official diagnosis. There's no test for it, but these women have quite often gone through a raft of other tests to try and exclude other things, and have settled to come to the conclusion that it's their implants that are causing this. And usually after a very long consultation and process with myself and Pauline, if we decide to remove the implants, a good 70% of those patients seem to have an improvement in their symptoms. So those women are in another category, and quite often which is an easy decision to make if you've decided that you're done with these implants, and actually you're happy for your breast shape to change. But if you love your implants and love how your breasts look, and you're having these symptoms, that can be a really really struggle of a decision for these women to come to.
And have things improved in terms of implant technology, so that if you were to have a newer model inserted instead, that you would potentially have a better outcome?
Absolutely. And at the sort of the textured implants, when we talk about texture, that's the surface on them, which were slightly sort of roughened, and the feeling was that would improve how your body would age around it. And now we know that that's the surface that seems to induce this lymphoma. So that was then that type of implant lost its CE mark back in 2019. And so we've moved to a smoother surface implant, which doesn't seem to have the same risk. What I would say is, though, we never really know. I can stand over where we think we are in terms of safety profile today, but I don't have a crystal ball, and I would be very open with patients saying this is as safe as I can guarantee it at this point in time. But we're always discovering more, and when anything is in your body for 15, 20 years, it's hard to predict how your particular body will respond to that. Again, while we can guarantee that they've been tested, there's always a new test. There's always something else. And so I'm very open with ladies that this is for today, this is the safest that I can make it.
Yeah.
But, we can't predict what we'll find out as time goes on. And, from that point of view, it's a bit like COVID in that, we know that one person in 100 will develop long COVID. We don't know why it's that person,
Yes.
but we know there's something special about that person that makes their immune system particularly vulnerable to it. And so it may be that if you're the one person whose breast implants don't agree with you, we can't predict that.
Of course. And I'm moving away from breast because it's not all that you
do.
No. So we've had a question about the stomach separation or muscle separation in pregnancy, and can that be treated? What does that involve?
Yeah. So the divarication of the recti muscles is where the six-pack muscles, which come together sort of at the level of your belly button, it's a perfect spot to create some space during pregnancy. So those six-pack muscles get separated during pregnancy, and the vast majority of those will go back together again with time. So with good attention to your core muscles and the input of physio and good core exercises, they will come back together. But for some women, they don't come back together. Yeah. And therefore and the bulge can bother them. They can get some backache because the muscles aren't working as efficiently at the front, and therefore they get a bit of tiredness in their back muscles. And that's mainly associated with other changes in the pregnant abdomen. It's very rare that I have a woman where I have just this bulge and everything else in her abdomen is entirely perfect. It's normally that everything has been stretched in pregnancy. And so there are stretch marks in the lower part of the abdomen, or there's a shelf of fat in the lower part of the abdomen, say following a C-section. And so as part of a tummy tuck, we generally would repair that separation in the muscles. If there is just a separation of muscles and no other concerns about the cosmesis of an abdomen, then that can sometimes be more in the remit of a general surgeon. And you would be talking about having a scar that would go in the midline, sort of above the belly button. But as I say, the vast majority of women, if you've had a pregnancy that's resulted in divarication of your recti muscles, there's usually some other signs in your abdomen that you may want to have improved at the same time, and that saves you having a scar in the middle of your abdomen. Instead, you have a scar sort of along the top of your pubic hair up towards your hip bones, more like a traditional tummy tuck scar.
So it sounds like you kind of achieve a number of different things then from that surgery. It does.
Yeah, it does, and everything's tightened up. So it's tightened up in the midline, but also we tighten up. There's another junction between your external obliques and your recti muscles, which also quite often give way, and just adds that impression of sort of a slightly doughy central part of your abdomen, which a lot of women experience after childbirth. And it's normally when the kids are now 5, 6 and 7 and they still feel that they have an abdomen that has never been back to normal again, and it gets them down, and they feel that they're forever trying to dress around it, and that's often at that stage then when they will make an appointment to come and see me.
Yeah, and I'm sure the results are fantastic. You're also, and connected I suppose to childbirth again, is the area of vaginal and perineal reconstruction, because it does take a battering in childbirth. Yes. And I suppose the women who've spoken to me have said they just push through. They don't want to introduce sort of more trauma or more kind of surgery to that area. So I wondered if you could reassure them in terms of what's involved there.
Yeah, and this is sort of an area that I mainly do in terms of cancer reconstruction. So people who are having cancer removed in that area, or even in male patients are having sort of parts of their back passage removed, and that area needs to be resurfaced using tissue from that area to rebuild it. But it's very similar techniques. If there was bad scarring from childbirth, it can be repaired. And I know you've had a chat with Patrick Campbell. He's a good colleague of mine, and we do a lot of joint cases together. And what he's able to do in terms of internal work and pelvic floor repair, and then I'm there to sort of supplement for the superficial stuff to make sure that there's tissue there that can resurface. And yes, it's one of those sort of difficult areas to talk about, but there are plenty of things that can be done, and the trick is to just get the conversation started.
Yes, and it won't be something that the medical team won't have seen before.
Definitely not.
In terms of, I suppose, looking ahead, trends in cosmetic procedures and plastic surgery, what do you see more of that you maybe wouldn't have seen 10 years ago?
I suppose the couple of things. First is male plastic surgery, men attending for cosmetic surgery, and actually there's a whole generation of men who spend a lot of time and are very concerned with their appearance, quite rightly so, and particularly in terms of their abdomen and their chest wall. So the difficulty with men and their chest wall is that not only do they want to look good in a t-shirt, but they want to look good whenever they're naked, because if they're at the gym or they're at the beach, they'll have their shirt off. So you're trying to do things through as minimal scarring as possible, or hiding scars in various ways. And not only are you looking to try and, say, remove excess body fat or excess breast gland, which can happen in men, but you're also trying to improve the appearance of their pectoralis muscle to try and give them that really sort of buff upper body appearance. And the great thing is we now have better techniques for that than we had before. So fat grafting is something that we've used for a long time in breast reconstruction, and has only really now become amenable for other patients. So that would involve liposuction to remove fat from where it's not wanted, and using that fat to inject into areas to try and improve those areas. So for men, it would be to remove the fat from, say, the lateral chest wall or their breast area, and then use that fat to inject into the pectoralis muscle to improve it, to then rebalance the chest wall, so you're having greater fullness in the top 2/3 of the chest and a sort of flatter appearance in the lower part. And those techniques are really going on at, a rampant pace. So recently I was in Miami at a big plastic surgery conference, and it's a huge procedure in Colombia, and they have sort of total body transformations where they're removing huge amounts of fat and injecting them into all different sort of muscle groups, including six-pack muscles, including upper arms, including, neck muscles, all the rest. And that can now be done safely through ultrasound guidance. And that's probably the next frontier that we're at. And as I say, it's been offered to my ladies either from a cosmetic point of view or for breast reconstruction from a point of view, and it's only now that the men are really starting to pay attention that this is something that we could change.
Okay. And does it sustain over a lifetime?
Yes, it does.
Well?
So approximately 70% of any fat cells that I move will survive. It's a bit like planting seeds. You need them to find a blood supply and survive. But the good thing about muscle is that muscle has a great blood supply. So if you have a muscle and you're injecting fat into that, those fat cells will survive. And actually, there's some good evidence that actually it will continue to encourage the muscle cells to grow as well. So not only is it improving the appearance of that muscle, but it's probably increasing the number of muscle cells and the size of those muscle cells, which whenever I'm speaking to my male patients, that's always what, that there's a small chance that they may be able to lift slightly more in the gym than they were before.
It's a win-win.
Yeah, absolutely. So that's a big thing. And that's really been tied in with more further advances in liposuction. So recently in Kingsbridge, we've acquired a Vaser liposuction machine, which uses ultrasound technology to break up the fat before we remove it. And the benefit of that is that it makes it a very seamless procedure to remove it with much less traumatic removal of the fat cells, which means that there are now, for smaller areas, we can do under local anaesthetic, which we never would have been able to do before. So that's a real new aspect, and maybe people who were reluctant to offer them, say, general anaesthetic because it's a small area, and is the risk of a general anaesthetic really balanced out by the benefit that you're going to get. And that really is taken away if we were able to do this area under local anaesthetic. So things like tops of arms, chins, lower abdomens, things, maybe upper inner thighs, that maybe it's a small area, and you wouldn't want a general anaesthetic or the downtime from that, but can be done now under local anaesthetic.
And presumably that downtime then is a lot less.
Much less, much less than it would have been with a general anaesthetic,
And I suppose just I wanted to ask you before we finished up, the being a female surgeon in a male-dominated environment, how has that been for you? And mindful that there's maybe people listening in who might want to go down that career path.
Yeah.
How's it been for you?
So surgery surgical training is undoubtedly a really hard course. It's a lot of long hours. It's physically quite demanding. There's a lot of standing on your feet for a long period of time. But it's massively rewarding, and I sort of feel like I've come out and managed to land myself in this lovely world where I have a lot of female patients, where actually my life experience as a woman and a mother, and as a woman who lives in a body every day, has really been of great benefit, and I get to draw on those personal experiences in order to interact with my patients, and so I feel that where I am in my career today, being a woman has great benefits, and I enjoy those interactions, and I enjoy the stories from patients about their lives and their families and their careers and where they're going, to great benefit. I think that surgical training probably needs to improve for everyone, and that even for my male colleagues it was tough, missing out on little ones' birthdays and important events and things like that, or just feeling that physically it takes a lot out of you, but at the same time that the reward is phenomenal at the end, and I really don't feel like I work for a living. I really do feel that I get to go every day and meet some new interesting people and get to do interesting procedures.
That's lovely to be able to say, and I think as a woman it's so lovely to have another woman looking after you. I think
and I think that I just never, so the first time I'd met a female surgeon who was successful sort of in her own right was I went to Canada for a year, and I was my husband was working and I was on maternity leave, and I just had a 3-month-old baby, and I met a female plastic surgeon there who's worldwide famous, and she was a single-handed woman practice, and had a very different interactions with her patients and had a very different interaction with her staff, and it really probably showed me for the first time that things can be done in a slightly different way. And so she was a great role model and great mentor to me. Her name is Elizabeth Hull Finlay. She's a huge pioneer for breast reduction surgery, and she was a huge inspiration to me. So I think I came home from Canada going, well, maybe this is possible. Maybe we can do it a different way, and haven't really looked back since then.
Well, you'll be a great inspiration to many female doctors in training. And I mean, if you can't see it, you can't be it, as they say. So,
exactly it.
And I suppose just to finish on a high, I'm sure you have lovely stories where you've really transformed people's lives. And you mentioned Patrick Campbell. He shared some on his podcast. Have you any you could share with us today?
Oh, so many. I think the main thing for me is that my patients inspire me every day, that they are so brave and they are so tenacious. So a patient who had her breast cancer and was coming up to her daughter's first communion. She was a single parent, and she was like, I need to be at that first communion. We need to get me through this. And, her sending me the photos of her on that day with her daughter, that goes in a special folder that I keep for myself, or women who've gone on to, climb mountains or run marathons, or just, be on holiday on the beach with their family and not feel self-conscious. Like, those moments are massively important to me, and I'm really, really proud that those patients share those with me, share those photos, share those moments with me. Another lady who had decided to have her breast implants removed because she was just at the end of the road with them. But her big stumbling block for her was that she had a number of children and had been breastfeeding for years. And after much discussion, we decided we think we can do this. And she sent me a photo when she got home that night of her day one post-op breastfeeding her baby, and sent me a picture of that. And that's a really important moment. So I feel like I get these little glimpses into this huge variety of really special moments, or transgender patients who have gone on to take up a job and show me a picture of them on their first day on the job. And in those moments are massively important to me, and I do keep those for days when things are difficult or a little bit stressful, or things haven't gone according to plan, to keep those to remind me of just how lucky I am to be involved in these women's lives.
That's fantastic. Thank you so much, Ciara. Thanks for joining us today. It was great to talk to you. I hope you enjoyed today's podcast, and remember to subscribe so that you're first to hear about the next episode.